Bismillahirrahmanirrahim. On to the 12th session of our CVS. So, restrictive infiltrative cardiomyopathy, decreased compliance of the ventricular endomyocardium that restricts the filling during the diastole. So, basically, the heart cannot dilate enough during the in the cases of restrictive myopathy. So, the causes are puppy-leash. So P is for the post-radiation fibrosis. If there is some sort of radiation exposure uh, to the thoracic cavity, Loeffler's endocarditis, endocardial fibroelastosis, thick fibroelastic tissue in the endocardium of the young children, amyloidosis, sarcoidosis, hemochromatosis. Although dilated cardiomyopathy is more common with hemochromatosis, but restrictive can also occur. What is Loeffler's or Loeffler endocarditis? It is associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates in the myocardium. The presentation is congestive heart failure. Classical finding is low voltage EKG with diminished QRS amplitude. Carcinoid heart. Carcinoid heart is basically a complication or a part of carcinoid syndrome. So right side endocardial fibrosis, endocardial thickening with restrictive cardiomyopathy and pulmonary stenosis. The diagnosis is plasma serotonin, urine 5-hydroxyindole acetic acid. Cardiac amyloidosis, deposition of abnormally folded protein, beta-pleated sheet conformation, localized amyloidosis, atrial natriuretic peptide, and diffuse amyloidosis leads to Ig light chains, immunoglobulin light chains. Localized amyloidosis confined to the cardiac atria, isolated atrial amyloidosis or IAA. The incidence of isolated atrial amyloidosis increases with age, reaching more than 90% in the ninth decade, like when the person is more than 90 years of age. This is a form of senile cardiac amyloidosis which may increase the risk of atrial fibrillation. Constrictive pericarditis. What are the features of constrictive pericarditis? Etiology: idiopathic or viral pericarditis, cardiac surgery or radiation therapy, tuberculosis in the endemic areas. Pathogenesis: thickened rigid pericardium forms a non-compliant casing surrounding the heart, limiting the ventricular expansion during the diastolic filling. Hemodynamic signs are increased jugular venous pressure, Kussmaul sign, pulsus paradoxus, and pericardial knock. CT scan will show thickening and calcification of the pericardium, and jugular venous pressure will show rapid and steep Y descent. What is stress-induced or Takotsubo cardiomyopathy? It is basically the Takotsubo is Japanese for octopus. It is a Japanese word or Japanese kind of octopus, but the problem is that the heart becomes dilated, and that happens in the old age people who are having some bad news or shocking news, and they can have a angina like symptoms or cardiomyopathy associated with that. Stress-induced cardiomyopathy most commonly affects the post-menopausal women. This condition is likely caused by the catecholamine surge in the setting of physical or emotional stress, for example, death of a loved one. Catecholamines may cause microvascular spasm, leading to ischemia and myocardial stunning, or they may cause direct myocardial dysfunction. Hypokinesis of mid and apical segments and hyperkinesis of the basal segments of the left ventricle, leading to systolic dysfunction and reduced ejection fraction. The resulting segmental left ventricular dysfunction creates a characteristic balloon shape on echocardiogram that mimics that of an octopus trap. That is, Takotsubo means octopus trap. It's not octopus, it is octopus trap in Japanese. Patients typically have chest pain that can mimic myocardial infarction and may also have symptoms of heart failure like dyspnea, lower extremity swelling. ECG often shows evidence of ischemia and ST elevation T-wave inversion in the anterior precordial leads. However, coronary angiography typically reveals an absence of obstructive coronary artery disease. The condition usually resolves within several weeks with supportive treatment only. Okay. Then we have acute myocarditis. So the acute myocarditis causes can be viral infection like Coxsackie virus, adenovirus, influenza virus, bacterial causes like tuberculosis, parasitic causes like Chagas disease, rheumatologic disease like systemic lupus erythematosus and rheumatic fever. Histopathology: myofibrillary necrosis accompanied by inflammatory mononuclear cell infiltrate consisting of lymphocytes and macrophages. Clinical presentation varies significantly. Many patients may remain asymptomatic with subclinical infection, but some experience severe complications including the decompensated heart failure like dyspnea, fatigue, peripheral edema due to the dilated cardiomyopathy. Ventricular arrhythmias leading to sudden cardiac death can also occur. Complications are sudden death. Major causes of sudden cardiac death in adults less than 40 years of age. Arrhythmias, heart block, dilated cardiomyopathy, heart failure, mural thrombus, and systemic emboli. So this is what acute myocarditis looks like on histopathology. Then we have the next question, that is heart failure. So for the heart failure, the clinical syndrome of cardiac pump dysfunction, congestion, and low perfusion. Clinically, the symptoms of heart failure are dyspnea, orthopnea, and fatigue. Signs are S3 heart sound, rales, jugular venous distension, and pitting edema. Systolic dysfunction includes decreased contractility and decreased ejection fraction with increased end diastolic volume, often secondary to ischemia, MI, or dilated cardiomyopathy. Diastolic dysfunction, this was systolic dysfunction, right, in which the heart does not want to contract. In diastolic dysfunction, the ventricles can't fill properly because during diastole the ventricles can't relax, the walls are so stiff, so there is preserved ejection fraction, normal end diastolic volume with decreased compliance and increased end diastolic pressure. Often it is secondary to myocardial hypertrophy. The pathogenesis of heart failure, firstly, there is decreased cardiac output. Okay, decreased cardiac output will lead to sympathetic nervous system activation. That will lead to increased heart rate and contractility, and this will maintain the blood pressure. Decreased cardiac output also causes renin-angiotensin activation, RAS activation, and antidiuretic hormone secretion. Now, this RAS activation will lead to vasoconstriction and increase in extracellular volume. Same is true for the antidiuretic hormone. And these vasoconstriction and extracellular volume, along with increased heart rate and contractility, maintain the blood pressure. This increased the hemodynamic stress, and these things, long-term neurohormonal activation, will lead to cardiac remodeling, and that causes further decrease in cardiac output, and this vicious cycle keeps on continuing. Drugs that decrease the mortality in heart failure are ACE inhibitors and angiotensin II receptor blockers, beta blockers except in acute decompensated heart failure, and spironolactone. Thiazide or loop diuretics are used mainly for the symptomatic relief. Hydralazine with nitrate therapy improves both symptoms and mortality in select patients. Then we have left-sided heart failure. So for the left-sided heart failure, there are different symptoms. Like if it is left-sided heart failure, so we are expecting pulmonary findings along with dyspnea and hypotension, right? If it is right-sided heart failure, so the lungs will be clear, but peripheral edema and jugular venous distension will be the main feature. And common features will be common to both of them, like orthopnea and nocturnal dyspnea and something. So orthopnea, shortness of breath when supine, increased venous return from redistribution of blood, immediate gravity effect exacerbates the pulmonary vascular congestion. Paroxysmal nocturnal dyspnea, breathless awakening from sleep, that is increased venous return from distribution of blood, reabsorption of peripheral edema, etc. So this is paroxysmal nocturnal dyspnea because heart is not pumping it, so it is accumulating in the lungs, and that is causing nocturnal dyspnea. Then pulmonary edema, increased pulmonary venous return, pulmonary venous distension, and transudation of fluid. Presence of hemosiderin laden macrophages, that is heart failure cells in the lungs, and treatment is NOLIP, that is nitrates, better than loop diuretics as 50% of the patients are euvolemic or hypovolemic. Oxygen, loop diuretics, inotropes, and positioning. Then decreased flow to the kidneys leads to activation of renin-angiotensin system. Fluid retention exacerbates the congestive heart failure, and mainstay of treatment is ACE inhibitors. Causes ischemia, hypertension, dilated cardiomyopathy, myocardial infarction, and restrictive cardiomyopathy. These things can lead to left-sided heart failure. Now, right-sided heart failure, the causes, most commonly it is due to the left-sided heart failure. Like initially it was left-sided heart failure that also precipitated the right-sided heart failure. Other important causes include left to right shunt and chronic lung disease like cor pulmonale. The clinical features are due to congestion, dependent pitting edema due to increased hydrostatic pressure, hepatomegaly, that is nutmeg liver, and this will be painful hepatomegaly. Increased central venous pressure leads to increased resistance to the portal flow, and painful hepatosplenomegaly rarely leads to cardiac cirrhosis as well. Like it can lead to liver cirrhosis because of cardiac etiology. Jugular venous distension because of increased venous pressure. How can left ventricular dysfunction lead to pulmonary hypertension? So if there is left ventricle is not pumping the blood, it is accumulating in the left ventricle and in the right atrium. I'm sorry, in the left ventricle and the left atrium. So the pulmonary veins will be engorged. So the blood will start pooling in the pulmonary capillaries, and that will lead to pulmonary edema. Reactive vasoconstriction due to venous congestion. If it is, yeah, like the blood is pooled in the veins, there will be pulmonary congestion, increased hydrostatic pressure, capillary leakage that will lead to pulmonary edema, alveolar collapse. Alveolar collapse will lead to decreased ventilation. That will lead to hypoxemia, reactive vasoconstricting to shunt the blood to the area of better ventilation. That will lead to pulmonary artery hypertension. That is the blood flow, the pulmonary arteries, like if I could make the concept a bit clearer. So this is the heart. Pulmonary arteries are originating from the right ventricle, right? And the pulmonary veins are draining into the left atrium. So if this is not going anywhere, if the blood from the left atrium or left ventricle is pulling inside, so there is venous congestion that will lead to pulmonary edema. The pulmonary edema will cause collapse of the alveoli. Now, as a rule, hypoxia in the lungs causes vasoconstriction. So these collapsed alveoli will produce hypoxemia and ultimately reactive vasoconstriction, and the pulmonary artery will then have a hard time to push the blood into the lungs. That will lead to pulmonary hypertension. Impaired nitric oxide availability and increased endothelin expression. Endothelin is a vasoconstrictor. Dysregulation of vascular smooth muscle tone and structural remodeling of the pulmonary vasculature. These are the two mechanisms by which the pulmonary hypertension is caused by the left ventricular failure. Causes of non-valvular heart failure. So, in the ischemic heart disease and dilated cardiomyopathy, these are the non-valvular heart failure causes: ischemic heart disease, dilated cardiomyopathy, hypertensive heart failure, hypertrophic cardiomyopathy, and destructive cardiomyopathy. Now, in the ischemic heart disease and dilated cardiomyopathy, the ventricular wall thickness decreases or stays normal. The ventricular cavity size increases in both of them. Contractile function decreases, and diastolic function is decreased or maybe normal. In hypertensive heart disease, it is kind of a diastolic stress on the heart, or diastolic may lead to diastolic failure as well. So ventricular wall thickness is increasing, ventricular cavity size will decrease, contractile function will be normal, and diastolic function will be decreased. Hypertrophic cardiomyopathy, again this is thickening of the ventricular wall to increase septal thickening. Ventricular cavity size will be decreased, contractile function will be normal, and diastolic function will be decreased. Then restrictive cardiomyopathy, ventricular wall thickness is normal, but the wall is stiffer because there is some external force that is causing the obstruction. Not obstruction, which is causing the restriction of the relaxation phase of the diastole. So the heart cannot relax properly. Ventricular cavity size will be decreased or maybe normal. Contractile function is normal, and diastolic function will be decreased. Dilated cardiomyopathy, systolic dysfunction, and hypertrophic cardiomyopathy leads to diastolic dysfunction. Then we have the next thing, the athlete's heart. So there is a difference between the normal heart and the athlete's heart. So I have to zoom it in. Now for the diagram, you can see that this area is the left atrium, left ventricle. This is the okay, I'm sorry, I messed it up. This bigger circle is the right ventricle. This smaller circle is the left ventricle, right? Now in the endurance athlete, for example a runner or a swimmer, there is thickened left ventricular wall, and okay, I again messed it up. Let's restart it. In the diagram, this smaller ventricle is the right ventricle, and this bigger ventricle is the left ventricle. Now let's restart it. So in the swimmers, there is thickening of the left ventricular walls. The walls are thickened, and the left ventricle, the lumen, is dilated. In strength athletes, weightlifters or wrestlers, there is thickening of the left ventricular wall and mild left ventricular dilation is there. And in combination athletes like the rowers or canoeists, gross thickening of the left ventricular wall with left ventricular dilation will be seen. This is normal heart. Then we have pathological remodeling. In hypertension, thickening of the left ventricular wall and no dilation in early stages of the disease. In dilated cardiomyopathy, thinning of the left ventricular wall and significant dilation will be there. And in hypertrophic cardiomyopathy, okay, so this hypertension can become dilated cardiomyopathy as well. Okay, like when the heart starts failing. And hypertrophic cardiomyopathy, gross thickening of the left ventricular wall, no dilation, decrease in left ventricular chamber. So this is that eccentric cardiac hypertrophy. So this is right ventricle and left ventricle. This is the concentric hypertrophy, in which the sarcomeres are added in parallel to each other and they cause the decrease in lumen size. In eccentric hypertrophy, the sarcomeres are added in series to each other and they increase the ventricular size. Okay. So in the systolic heart failure, it is eccentric hypertrophy that happens, and in the diastolic heart failure, we are expecting concentric hypertrophy. Then what is shock? Inadequate perfusion and delivery of nutrients necessary for the normal tissue and cell function. Cellular function initially may be reversible but life-threatening if not treated promptly. There are four different types of shock: hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. Hypovolemic shock is caused by hemorrhage, dehydration, and burns. Burns cause dehydration mainly. The skin in this kind of shock will be cold and clammy. The pulmonary capillary wedge pressure, the preload, or the left atrial pressure will be decreased because there is not enough blood to enter the heart. The cardiac output will be decreased. Systemic vascular resistance of the afterload will be increased in an attempt to maintain the blood pressure. It will be a sympathetic reflex vasoconstriction, and treatment is in the IV fluids. In cardiogenic shock, acute MI, heart failure, valvular dysfunction or arrhythmia, as the name indicates, it is because of some cardiac problem. And for the obstructive shock, it is like hypertrophic obstructive cardiomyopathy, in which the blood cannot leave the heart, like in the cases of cardiac tamponade or pulmonary or tension pneumothorax. So even in these situations, the skin will be cold and clammy. The pulmonary capillary wedge pressure may be decreased or increased. The cardiac output is decreased. Systemic vascular resistance is increased. The treatment of cardiogenic shock is with the inotropes and diuresis, and obstructive shock is to relieve the obstruction. This thing that is the distributive shock. So in the distributive shock, the heart is functioning normally, but the vessels are so dilated, they are so dilated that there is pooling of the blood in the systemic circulation, and that is what that is exactly what is causing the shock. So distributive shock is caused by the sepsis, anaphylaxis, and CNS injury. Skin will be warm and dry. It is a warm type of shock. Neurogenic shock comes in this variety. Pulmonary capillary wedge pressure will be decreased. Okay, so there are two types. In sepsis and anaphylaxis, the skin will be warm. The pulmonary capillary wedge pressure will be low. Cardiac output will be high, and systemic vascular resistance will be low. In the cases of CNS injury, the pulmonary capillary wedge pressure will be low, the systemic vascular resistance will be low, but along with that, the cardiac output will be low. In sepsis, the cardiac output is high. So the treatment of both of them is IV fluid, pressors, epinephrine, and anaphylaxis. That is the treatment. Epinephrine if there is anaphylaxis. Infective endocarditis. Inflammation of endocardium that lines the surface of cardiac vessels, usually due to bacterial infection. Causes are acute staph aureus, high virulence, large vegetations on previously normal valves, rapid onset. Staph aureus is most common cause in IV drug abusers. High virulence organisms that infect the normal valves, most commonly the tricuspid, results in large vegetations that destroy the valve. Subacute viridin streptococci. Just give me a second. Subacute viridin streptococci, low virulence. We were talking about infective endocarditis. So acute is caused by the staph aureus. Subacute one is caused by the viridin streptococci. The most common overall cause is also staph viridans. It is a low virulence organism that infects previously damaged valves like chronic rheumatic heart disease and mitral valve prolapse. It results in small vegetations that do not destroy the valve. Subacute endocarditis. Sequelae of dental procedures, and it is a gradual onset. Damaged endocardial surface develops thrombotic vegetations, platelets, and fibrin. Transient bacteremia leads to trapping of bacteria in the vegetations. Prophylactic antibiotics decrease the risk of endocarditis. Then we have Staphylococcus epidermidis. It is associated with endocarditis of the prosthetic valves. Strep bovis, associated with the endocarditis in the patients with underlying colorectal carcinoma. Hasek organisms, Haemophilus aggregativector, formerly Actinobacillus, Cardiobacterium, Echinella, and Kingella, associated with endocarditis with negative blood cultures. What is the pathogenesis? The initial process is a disruption of normal endocardial surface. This occurs most commonly at the areas of maximal turbulence to the blood flow in pre-existing valvular lesions, typically the atrial surface of incompetent atrioventricular valve or the ventricular surface of incompetent semilunar valves. This is followed by focal adherence of fibrin and platelets, forming a sterile fibrin platelet nidus. During bacteremia from any cause, microorganisms colonize the sterile nidus on the endothelial surface with subsequent microbial growth leading to further activation of the coagulation system. Streptococci infect the cardiac valves with pre-existing endothelial lesions. In contrast, Staphylococcus aureus can adhere to the damaged or normal endothelial cells. The clinical features of bacterial endocarditis include fever, murmur, skin manifestations, and anemia. So, firstly, we'll talk about the fever. So, fever is due to bacteremia. Progressive fatigue may be the presenting symptom of infective endocarditis. Murmur, due to vegetation on the heart valve. Mitral valve is most frequently involved. Tricuspid valve endocarditis is associated with the IV drug abuse. Skin manifestations, JNV lesions, erythematous non-tender lesions on the palms and soles. Osler nodes, tender lesions on the fingers or toes. Splinter hemorrhages in the nail bed due to embolization of septic vegetations. Anemia of chronic disease due to the chronic inflammation. So vascular and immunologic manifestation of infective endocarditis are vascular phenomena and immunologic phenomena. So vascular phenomena, systemic emboli, cerebral, pulmonary or splenic infarcts, mycotic aneurysms, JNV lesions, that is macular erythematous non-tender lesions on the palms and soles. Immunologic phenomena, osseous nodes are painful, violaceous nodules seen on the fingertips and toes, and Roth spots are erythematous and hemorrhagic lesions of the retina. So these are bacteria from Jane. So these are the mnemonic for the infective endocarditis, like fever, Roth spots, Osler nodes, murmurs, JNV lesions, anemia, nail bed hemorrhages, and emboli. Okay. I think the Roth spots are on the retina. Let me confirm that, but I think that they're on the retina. And Osler nodes and JNV lesions are present on the fingertips. So the Roth spot. Sorry. I'm searching on the mobile actually. This Roth spots are, yes, they are white center. These are Roth spots, right? Then these are Osler nodes. These are JNV lesions, and these are splinter hemorrhages of the nail bed hemorrhages. Okay, JNV. JNV lesions are irregular non-tender. So JNV lesions are non-tender. Remember that they're on the palms and soles. Like these are the JNV lesions, and they will be non-tender. Osler nodes. O is for ouch, and O is for the Osler nodes. So they are painful. And yeah, Osler nodes are thought to be caused by localized immunologic mediated response, while JNV lesions are thought to be caused by septic microemboli. And Osler nodes are on the tip of the finger and toes, and they are also painful. Got it. Then the next thing is these are the Osler nodes, to be specific. These things. Okay. Laboratory findings: positive blood cultures require multiple blood cultures for the diagnosis. If culture is negative, most likely Coxiella bruneti, Bartonella species or Hassek organisms. Anemia of chronic disease, decreased hemoglobin, decreased mean corpuscular volume, increased ferritin, decreased total iron binding capacity, decreased serum iron, and decreased percent saturation. Transesophageal echocardiogram is useful for detecting the lesion on the valves. Then we have non-bacterial thrombotic endocarditis, NBTE or mesenteric endocarditis, sterile platelet-rich vegetations that arise in association with a hypercoagulable state or underlying adenocarcinoma. Vegetations arise on the mitral valve along the lines of Cloyer and result in mitral regurgitation. The first one is Libman-Sack endocarditis, LSE, which is associated with SLE. Due to sterile vegetation that arise in association with SLE, vegetations are present on the surface and undersurface of the mitral valve and result in mitral regurgitation. Pathogenesis begin with valvular endothelial injury caused by the inflammatory cytokines, which trigger platelet deposition in the presence of an underlying hypercoagulable state. Causes most commonly associated with the advanced malignancy, especially mucinous adenocarcinoma, systemic lupus erythematosus like Libman-Sack endocarditis, and less commonly by the antiphospholipid syndrome, DIC, and extensive burns. Histology: non-bacterial NBTE, non-bacterial uh, endocarditis, non-bacterial thrombotic endocarditis. Vegetation consists of bland thrombus with strands of fibrin, immune complexes, and mononuclear cells like white thrombus. The vegetations typically affect the left-sided heart valves, mitral or aortic, and are often asymptomatic. However, systemic embolization like stroke, acute limb ischemia can occur, and is the most common presentation of non-bacterial thrombotic embolism. Osler nodes are due to immune complex deposition. JNV lesions are due to septic emboli. So you have to remember the pathogenesis. Like septic emboli, when they come and clog the blood vessels, they form Janeway lesions and they are not painful. Osler's nodes, Osler nodes are due to the immune complex deposition and they are on the fingertips and they are painful. Effect of endocarditis on the kidney. If microemboli, they can cause hematuria. If immune complex deposition, acute diffuse proliferative glomerulonephritis, nephritic syndrome, hematuria, proteinuria, red cell cast, and increase in serum creatinine. Uval point is native valve bacterial endocarditis will lead to mitral valve collapse, the most common cause then right heart disease. For the native valve endocarditis, mitral valve collapse is the most common cause. Then comes the right heart disease, rheumatic heart disease. I'm sorry. Then comes the rheumatic heart disease. It is rheumatic heart disease. Uval point is tricuspid endocarditis with pleuritic chest pain, septic pulmonary emboli. The least organ to be affected by the thromboembolism of infective endocarditis is liver due to dual blood supply. Then we have cancer with non-native valve bacterial endocarditis due to hypercoagulable state caused by circulating products of cancer, which is procoagulable, for example, Trocheau's syndrome, migrated thrombophlebitis due to visceral malignancy. What is rheumatic fever? Acute rheumatic fever, systemic complication of pharyngitis due to group A beta streptococci, beta hemolytic streptococci, affects children 2 to 3 weeks after an episode of streptococcal pharyngitis, which is strep throat. Caused by molecular mimicry, bacterial antigens M protein, N acetyl beta, D-glucosamine resembles protein in the human tissue, heart, and CNS. Pathophysiology of acute rheumatic fever. Group A streptococcal pharyngitis. It has surface proteins which mimic the M protein. They will activate the beta cell and CD4 positive cells, and these antibodies will then target the myosin protein of the heart as well. Cross-reactive response against the cardiac proteins. Carditis with the Aschoff bodies and valvulitis will be seen. Acute rheumatic fever, the epidemiology is endemic in developing countries. Pathogenesis, molecular mimicry. Anti-group A streptococcal antibodies attack the host antigens of the cardiac and neuronal tissue approximately 2 to 4 weeks after acute pharyngitis. The clinical features are acute, subacute migratory arthritis, pancarditis, Sydenham chorea. For the chronic cases, mitral regurgitation and stenosis is seen. Prevention, prompt treatment of streptococcal pharyngitis with penicillin. Diagnosis is based on the Jones criteria. There are minor criteria as well, but the Jones is the major criteria. Evidence of group A beta hemolytic streptococcal infection, for example, elevated ASO or anti-DNase B titers, with the presence of major and minor criteria. Minor criteria non-specific include fever and elevated ESR. So they're like fever and elevated ESR and some other characteristics. For the major criteria, so these are the Jones criteria. Firstly, joints, migratory polyarthalgia, polyarthritis, swelling and pain in a large joint like wrist, knees, ankles that resolve within days and migrates to involve other larger joints. Pancarditis can be endocarditis, myocarditis, and pericarditis. Endocarditis, mitral valve is involved more commonly than the aortic valve, characterized by small vegetations along the line of Cloyer that leads to regurgitation. Myocarditis is the most common cause of death during the acute phase. Causes cardiac dilation. Functional mitral regurgitation will lead to heart failure and S3 gallop. Aschoff bodies that are characterized by the foci of chronic inflammation, reactive histiocyte with slender wavy nuclei, and cells, giant cells, and fibrinoid material. Pericarditis leads to friction run and chest pain. Then we have subcutaneous nodules. Erythema marginatum, annular non-pruritic rash with erythematous borders, commonly involving the trunk and limbs. Sydenham chorea, a hyperkinetic extrapyramidal movement disorder, the most common acquired chorea of childhood, restlessness and purposeless jerking movements, latency 2 to 3 months after sore throat, diagnosis by the antineural antibodies binding to the caudate and subthalamic nuclei. Acute attack usually resolves but may progress to chronic rheumatic heart disease. Repeat exposure to group A beta hemolytic streptococci result in relapse of acute phase and increase in the risk of chronic disease. Then we have Aschoff bodies, focal areas of interstitial inflammation characterized by fragmented collagen, mononuclear NHCO cells, multinucleated giant cells or Aschoff cells. Chronic rheumatic heart disease, valve scarring that arise as a consequence of rheumatic fever. So basically, in the chronic rheumatic heart disease, the valve becomes scarred, results in stenosis with a classic fish mouth appearance. Almost always involves a mitral valve, leads to thickening of the chorda tendineae and cusps. Occasionally involves the aortic valve, lead to feeling of the commissures. Other valves are less commonly involved. Complications include infectious endocarditis. So these are acute rheumatic heart disease. A is showing mitral vegetations. These ones, B is showing ash of bodies involving the myocardium. What are ash of bodies? These are NH-core cells. Yeah, so I think this whole thing is ash of bodies. Then we have acute pericarditis. As the name indicates, it is the inflammation of the pericardium. So this is the inflammation of pericardium as indicated by the red arrows. So these arrows are depicting the inflammation of myocardium, pericardium, commonly present with sharp pain aggravated by inspiration and relieved by sitting up and leaning forward, often accompanied by the pericardial effusion between the yellow areas. Now, between the yellow areas, you can see this dark line. This dark line is depicting the pleural effusion. No, pericardial effusion. I'm sorry. Pericardial effusion. Patient present with a friction rub. You can hear the friction rub with the stethoscope. ECG changes include widespread ST segment elevation and or PR depression. Causes include idiopathic, most common, presumed viral. Confirmed infection, for example, Coxsackie B, neoplasia. Autoimmune, for example, SLE and rheumatoid arthritis. Uremia, cardiovascular, acute STEMI or Dressler syndrome, and radiation therapy. So here we can see the etiologies of pericarditis. Firstly, infection. Viral is the most common, then comes bacterial. Iatrogenic, surgery, trauma, radiation, and drug related. Connective tissue disease like rheumatoid arthritis, systemic lupus erythematosus. Cardiac manifestations, the Dressler syndrome, post-myocardial pericarditis, usually 1 to 6 weeks after the myocardial infarction. Uremic, serum blood urine natriuretic usually more than 60 mg per deciliter, but the degree of pericarditis does not always correlate with the degree of elevation. Malignancy can be due to cancer, for example, lung and breast, Hodgkin lymphoma, or treatment, for example, radiation and chemotherapy. Triphasic friction rub occurring during the atrial systole, ventricular systole, and early ventricular diastole on the cardiac auscultation. However, the rub can be absent if significant pericardial effusion is present. Types of acute pericarditis can be fibrinous, hemorrhagic, and purulent pericarditis. So, fibrinous pericarditis, the most common type of pericarditis. It is characterized by the pericardial inflammation with a serous that is fibrin containing exudate in the pericardial space. Common cause includes viral infection, myocardial infarction, uremia, and rheumatologic disease, for example, systemic lupus erythematosus and rheumatoid arthritis. Hemorrhagic pericarditis is malignancy and TB. The causes of this one are malignancy and TB, followed by cardiac surgery or in the patient with an underlying coagulopathy. Purulent pericarditis results from active bacterial infection like Staphylococcus aureus and Streptococcus in the pericardial space, which may occur due to hematogenous spread or direct extension of the pneumonia or endocarditis. Then we have constrictive pericarditis. So the etiology is idiopathic or viral pericarditis, cardiac surgery or radiation therapy, tuberculosis in the endemic area. Pathogenesis. Rigid pericardium prevents the ventricular expansion and restricts the diastolic filling. And predominantly it can show the right-sided manifestation because the right-sided right heart is low pressure system in comparison to the left side. So when there is some constrictive pressure from outside, so the first thing to be affected is the right-sided heart. Then we have physical examination. So because right side is affected more, so increased jugular venous pressure, pericardial knock, pulsus paradoxus, and Kussmaul sign. What are the features of constrictive pericarditis? So idiopathic or viral pericarditis is the etiology. Cardiac surgery or radiation therapy and tuberculosis in the endemic areas. Pathogenesis will show thickened right pericardium forms a non-compliant casing surrounding the heart, limiting the vascular expansion in the diastolic filling. Hemodynamic signs are increased jugular venous pressure, Kussmaul sign, pulsus paradoxus, and pericardial knock. So here you can see that we have this white line is showing the fibrinous pericarditis causing constrictive pericarditis. Okay. Then we have cardiac tamponade. So cardiac tamponade and pericarditis are kind of similar. Like in fibrinous pericarditis, it is a fibrinous exudate which is present in the pericardial cavity. In cardiac tamponade, it will either be blood or maybe some sort of fluid. So it is compression of heart by a fluid, blood or effusions in the pericardial space that will decrease the cardiac output. The clinical features of cardiac tamponade, the etiology is malignancy or radiation therapy, infection, for example, viral tuberculosis or HIV, drugs like hydralazine and isoniazid, connective tissue diseases like systemic lupus erythematosus and rheumatoid arthritis. The clinical signs are Beck's triad, like jugular venous distension, hypotension, and diminished heart sounds. Pulsus paradoxus, abnormally large inspiratory decrease in systolic blood pressure more than 10 millimeters of mercury, and also there will be increased heart rate. So yeah, normally when we inspire, so there is a decrease in the blood pressure because of during inspiration, the blood is entering into the uh, when we are inspiring, the thorax is expanding and the return of the blood to the left side of the heart is decreased, and that can decrease the blood pressure to some certain extent, but not more than 10 millimeters of mercury. If it is going more than 10 millimeters of mercury, then it is pulsus paradoxus. Diagnosis is by the ECG, low voltage QRS complexes and electrical alternance. You must remember these words, electrical alternance, because the heart, like suppose this is the heart and this is the pericardial sac, the heart is literally swinging inside and outside in the pericardial space because of the excessive amount of fluid that is present. Now here is our probe, the ECG lead. So when the heart comes close, the ECG tracing goes up, and when it goes backward, the ECG tracing goes down. So this is not basically I'm sorry, this is not ECG tracing. This is pulsus paradoxus. This is the ECG tracing. So here you can see electrical alternance in this line. Like this is sorry. So here you can see we were talking about electrical alternance. I'm sorry, there was an interruption. So the electrical alternance, here you can see that this QRS complex is bigger in comparison to this one and like this one. So this is because of swinging of the heart in the pericardial space. So coming back, diagnosis is made by the ECG leads, which will show low voltage QRS complexes and electrical alternance, and chest X-ray will show enlarged water bottle shaped heart and clear lungs. Equilibrium of diastolic pressure in all four chambers. Pulsus paradoxus has decreased in amplitude of systolic blood pressure by more than 10 millimeters of mercury during inspiration. It is seen in cardiac tamponade, asthma, obstructive sleep apnea, and pericarditis, and also croup. So there are multiple conditions which can show pulsus paradoxus. Cardiac tamponade is one of them. So this is pulsus paradoxus. Like when the person is inspiring, so the blood pressure is dropping down, and when expiration is happening, so blood pressure is coming back to normal, and then again. And this is, you can see this right ventricle, and this is the pericardial fluid that is present in the pericardial space. This is electrical alternance, varying amplitude of the QRS complex. We have talked about that. A Uworld question is a case. For example, a patient presents to you with mild respiratory illness 1 week ago. Now hypotension, tachycardia, jugular venous distension, pulse is undetected during inspiration, lungs are clear on auscultation. The diagnosis is cardiac tamponade due to serious viral pericarditis. NBME point is differential diagnosis of acute jugular venous distension with hypotension and tachycardia. So it is cardiac tamponade, leads to clear lungs. If it is cardiac tamponade, there will be clear lungs on auscultation. If it is tension pneumothorax, so there will be diminished air entry. Why not fibrinous pericarditis? Because pleuritic vein infection that should be present. Why not constrictive pericarditis? Because that requires months to years to produce cardiac tamponade. Syphilitic heart disease. It is present in tertiary syphilis, which disrupts the vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilation of the aorta and valve ring. May see calcification of the aortic root, ascending aortic arch, and thoracic aorta, leads to tree bark appearance of the aorta. It can result in aneurysm of ascending aorta or aortic arch and aortic insufficiency. Talking about cardiac tumors, they are rare, but they can be present. Myxomas are the most common type of cardiac tumors. Most common heart tumor is a metastasis, for example, melanoma. So there is a tumor of some other site that has metastasized to the heart, like melanoma. Myxomas are the most common primary cardiac tumors in the adults. 90% will occur in the atria, most common in the left atrium. Like this is a myxoma. Okay. Myxomas are usually described as a ball valve obstruction in the left atrium associated with a multiple syncopal episodes. May auscultate early diastolic tumor plop sound. Histology will show scattered cells in the mucopolysaccharide stroma. These are scattered cells, they're not red cells, I'm sorry, these are scattered cells in the mucopolysaccharide stroma. This is the mucopolysaccharide stroma, and these are islands of cells with abnormal BV. What is BV? With blood vessels. Okay, so with abnormal blood vessels and hemorrhage. Gelatinous material, myxomal cells immersed in the glucosaminoglycans. Okay. Rhabdomyomas, most frequent primary cardiac tumor in children associated with tuberous sclerosis. Histology is hematomatous growths. Okay. Valvular disease introduction. So for the valvular diseases, the mechanical degeneration is the leading cause of valvular heart diseases in the US. Rheumatic fever in the developing world. So because rheumatic fever is not very common in the United States, In US, the most common cause of valvular diseases is mixomatous degeneration of the valves, auscultation of hollow systolic murmur, mitral regurgitation, tricuspid regurgitation, and VSDs. These produce hollow systolic murmurs. Now, for the mitral regurgitation, it is best heard at the apex and radiates to the axilla. Tricuspid regurg, best heard at left, second, and third intercostal spaces. Murmur is increased with inspiration because it is a right-sided murmur. All right-sided murmurs increase on inspiration, while all the left-sided murmurs they increase on expiration. Their intensity increases on expiration. Then we have the next thing, that is ventricular septal defect. It is best heard at the left, third, and fourth intercostal spaces. Murmur is usually loud and accompanied by a thrill. Auscultation of murmurs. So, on inspiration, changes in cardiac parameter increase venous return to the heart and decrease increase venous return to the right heart and decrease venous return to the left heart. Most right-sided murmurs are increased in intensity with inspiration, and most left-sided murmurs decrease in intensity with inspiration. Valsalva strain phase or abrupt standing. Valsalva strain phase decreases the preload, and abrupt standing also decreases the preload, and that also somehow decreases the afterload. How does that decrease the afterload? Afterload, when you are standing abruptly, the preload is decreased and the afterload is decreased. Maybe. So in these, by the way, Valsalva strain phase and abrupt standing, both of them cause an increase in the mitral valve collapse and hypertrophic cardiomyopathy because low ventricular volume and small chamber size is present. Most other murmurs will be decreased, like decreased flow through the stenotic or regurgitant valve. Squatting increases the preload and afterload, and passive leg raise increases the preload. Most of the murmurs will be exaggerated because of increased flow through the stenotic or regurgitant valve, but mitral valve collapse and hypertrophic cardiomyopathy will be decreased in intensity, like increased left ventricular volume. With hand grip, afterload increases, so aortic regurgitation, mitral regurgitation, VSD will be loud because of increased left volume, left ventricle, and aortic pressure. Hypertrophic cardiomyopathy will be decreased because of increased left ventricular volume, and aortic stenosis will be decreased because of decreased transvalvular pressure gradient. I hope this makes sense because of the increased chamber size. About aortic stenosis, suppose this is the left side of the heart. In the left side of the heart, this is the aortic valve. Now this is stenotic aortic valve, right? So if the pressure difference is too high, like if it is 170 in the systemic circulation, just maybe it on in during diastole is 25. So the pressure gradient is too much, right? But if we are in no, I'm sorry, I was just confusing myself. Listen, they're saying that the pressure gradient decreases if we increase the afterload. So the ventricle, if you remember the cardiac graphs, like suppose this is the aortic curve with the dichrotic notch and something, and the ventricular curve was going all the way up and then coming down. Remember? So the ventricular pressure is higher than the aortic pressure because of the stenotic aortic valve. Like suppose this is 140, while in the aorta we are having 100 or 120 millimeters of mercury pressure, right? So if we increase the afterload and this pressure becomes 130, so the murmur intensity will decrease because the gradient will decrease and the flow will also decrease to some extent. Okay, moving forward, now we have the aortic stenosis. Aortic stenosis is the stenosed aortic valve which will produce a systolic murmur due to turbulence as the blood hits the stenotic aortic valve, and it has a classic sound that is crescendo, decrescendo murmur. Causes are mechanical, like wear and tear resulting in dystrophic calcification. Calcific degeneration is the most common cause. Chronic rheumatic fever is characterized by fusion of valve commissures, but more likely to damage the mitral valve. Most types most common in the elderly patients. And the congenital one, unicuspid or bicuspid defects in the pediatric patients. Presentation. They are asymptomatic until very advanced. Rapid progression, one symptomatic within 5 years. Elderly patient more than 60 or younger patient with bicuspid aortic valves present with the exertional angina due to decreased coronary perfusion. Exertional syncope and dyspnea. The heart is unable to adequately increase the cardiac output during the exercise. Concentric left ventricular hypertrophy leading to the congestive heart failure. What will be the auscultatory findings? Firstly, they will be paradoxically split of S2, which means that normally S2 is like A2. and P2. But in these situations, pulmonary component comes first, right? And secondly, the split is heard or auscultated during inspiration, and then it fades during expiration, right? Because when we are inspiring, there is increased amount of blood that is moving from the pulmonary artery, and then the split is heard. But in these situations, because of stenosed the aortic valve is closing late, right? So when we inspire, the pulmonary component moves close to the aortic component, and the split is diminished during the inspiration. That is also a paradoxical thing. So everything is paradoxical about this thing. So the next thing is the paradoxical split. Normal split S2 is during the inspiration due to the delayed pulmonary valve closure. When aortic valve is stenotic, it closes later than the normal, producing a single S2 sound on inspiration, closing of the valve aligns, and a split S2 on expiration due to the aortic valve closing late. There will be a crescendo-decrescendo systolic murmur, classically heard in the second right intercostal space with radiation to the carotids. It peaks in the early systole. The later the peak in systole, the more advanced the stenosis. Decreased preload decreases the murmur intensity, that is less blood passing through the stenotic valve, and ejection click may be heard, that is ejection type systolic murmur. Pulses parvus et tardus, which means that there will be slow rising carotid pulses, and also they will be weak. Weak and late pulse due to the pressure lost traversing the stenotic valve. Ejection velocity of the blood increased due to same amount of blood needing to pass through the smaller valve area. Speed directly proportional to the degree of stenosis. So this is hemodynamics of severe stenosis. Firstly, severe stenosis impairs the left ventricular output. Got it. Then that higher systolic pressure causes left ventricular hypertrophy, as you can see here, and atrial contraction necessary for the filling of stiffened ventricle. So basically, now the ventricle is going in diastolic failure. Normally, most of the blood from the atrium to the ventricle is moved in a passive fashion, but now because of the stiff ventricular walls, atria has to contract to push the blood into the ventricles. So atrial fibrillation is also contraction reduces the left if due to some reason, and because of more very obvious reasons, because there is too much blood already in the ventricles, because this is stenosed aorta, the atrium may start dilating, right? So that may precipitate atrial fibrillation, and if there is atrial fibrillation, there will be reduced left ventricular filling, causing hypotension and pulmonary edema in such patients. Now let's talk about pulmonary stenosis. Now for all the left-sided problems like aortic stenosis, we have a counterpart, that is pulmonary stenosis, which is less severe with similar murmur findings, but on a different area on chest. So that makes sense. Similar to aortic stenosis, but softer due to the lower pressure in the pulmonary circuit, and it is also uncommon. These valvular problems, all of them are common on the left side, because left side is high pressure system. All the valves are subjected to very high pressures on the left side. So that is why the valvular problems, because of mechanical issues, are more common on the left side. Aortic regurgitation, diastolic murmur due to the blood shooting back through the aortic valve during the diastole. The causes can be rheumatic fever, aortic root or ascending aortic systemic hypertension, endocarditis, aortitis, for example, syphilis. I'm sorry, they were not like that. So for the leaflet problems are rheumatic fever, endocarditis, trauma, and bicuspid aortic valve. Aortic root or ascending aorta can be affected like in systemic hypertension, aortitis like syphilis, ankylosing spondylitis, trauma dissecting aneurysm, Marfan syndrome, Ehlers-Danlos syndrome, and inflammatory bowel disease. So these are different causes of aortic regurgitation. It presents with worsening exertional dyspnea and orthostatic hypotension. Auscultative finding will show a decrescendo diastolic murmur in the aortic regurgitation. It is early diastolic, blowing long decrescendo murmur heard at the left sternal border. Austin Flint murmur. It is low pitched mid to late diastolic rumble, heard best at the apex of the heart, and it is associated with severe aortic regurgitation. So this Austin Flint murmur, we find a regurgitation murmur. Also along with that, if it is severe aortic regurgitation, then we find Austin Flint murmur, which is a mid to late diastolic rumble, which is heard at the apex of the heart and is associated with severe aortic regurg. Aortic valve so regurgitant that the blood jets back into the left ventricle, hits anterior leaflet of the mitral valve, or regurgitates into the left atrium. So that is Austin Flint murmur, and that produces a problem like that. Okay. Then we have other signs of aortic regurgitation. So that can be head bobbing, which is also called as a de Musset sign, due to the wide pulse pressure. Corrigan's pulse, carotid pulse with rapid fall and rise. Hyperdynamic water hammer pulse. Femoral bruit on the compression of the femoral pulses. So then we have the pathophysiology. The pathophysiology of the aortic regurgitation. Chronic aortic regurgitation will lead to decreased diastolic blood pressure. That will lead to widened pulse pressure and hyperdynamic circulation. Increased left ventricular and diastolic volume will lead to eccentric hypertrophy. Initially, compensatory increase in stroke volume will lead to increased systolic blood pressure, and that will lead to widened pulse pressure and hyperdynamic circulation. But over time, there will be left ventricular dysfunction and heart failure. So, before going to minor stenosis, I would like to finish this pulmonic regurgitation. So, diastolic murmur, pulmonic regurgitation is the murmur is similar to that of the aortic regurgitation. It is a diastolic murmur, similar to aortic insufficiency or regurgitation, but softer due to low pressure in the pulmonic circuit, and that is uncommon as well. So this is the one, and we'll continue with the mitral stenosis in the next session. Until then, Allah Hafiz, Fi Amanillah, and take care.